Nothing contained in this podcast should be considered a substitute for professional medical advice. This content does not represent our respective employers and is purely the opinion of the podcast hosts. We are not your personal medical providers. Sorry, friends. So, if you have any questions or concerns or seeking advice, diagnosis, and or treatment, please seek individual, personalized advice from a healthcare provider in your area. We are not liable for any risks or issues associated with using or acting upon the information contained in this podcast. This is intended for educational and entertainment purposes only, so enjoy the ride. Welcome to Medical Media Mixer, the perfect cocktail. I'm Nicole Peniston, clinical psychologist.
I'm Tara Prisco, physician assistant. All right, back again on a weeknight.
We are. I almost said, I'm Dr. Peniston. I'm like, you people aren't going to know who I am. I'm not your doctor. Sorry. It's automatic sometimes.
I know.
Which took a very long time to get used to calling myself that.
Yeah, I'm sure. And it's what's interesting is then my patients, they feel informal calling me Tara. I just introduce, I'm Tara, the physician assistant. And I could say PA Prisco, but like, I don't know.
Weird.
That it doesn't sound right to me. So,
my very first day, like working as like an official doctor, it was like an early morning patient. There was nobody in the office. I was there, and they like came in and I went out to the waiting room, and I was like, "Oh, hi, like, are you so and so?" And they're like, "Yeah." And I was like, I didn't even think. I was like, "Dr. Peniston will be right with you." And I was like, "Oh God, that's me."
I spoke about myself in the third person.
And then I had to come back out. I'm like, "Come on back," and they're like, "Oh, you?" And I was like, "Sorry, it's an off day."
Awkward.
I mean, it's awkward though, like calling yourself a title for the first time, especially.
Right. I can see that. Yeah.
It still sometimes weirds me out. I'm like, what? Okay, whatever.
I'm still me.
Yeah, my first name is not doctor.
So I actually had to cancel all my patients tomorrow because we have a gymnastics meet. And
yes.
It's a Friday because, people don't have work and school.
Yeah. No such thing as school for children.
At 11 o'clock on a Friday. So, whatever. It's fine.
Is it far?
It's like a little over an hour. It's actually near you. It's in Hamilton.
Oh,
so
nice.
It's not that far from, sort of near you.
Yeah. Don't tell everyone where I live.
I'm giving you a corner of a whole state. I think we're good.
Okay.
Yeah, so we have that. And then next weekend, I have our first dance competition for the little one.
Mm-hmm.
And that is a 7 a.m. report time in full glam makeup, which I have yet to practice on her.
Oh, Lord. Well, tomorrow, if you are free, I work from home tomorrow, so I can always pop over and say, hey.
You want to come see some gymnastics?
Sure, why not? If I'm disciplined and get my work done, then yes, I will have time to do that.
So yeah, I'll be down there. We'll see how that goes. It's like a little over an hour, I guess. So,
yeah, not too
bad. Yeah, not too bad. It's not early. It's like 11. So doable. All right. We ready to get down to it?
I think we are. And I believe I go first this time.
You do.
So my drink today is a shot. I was inspired by your shots from last week.
Shot.
The problem is I did not have a double shot glass, and this required that because of the amount of liquid. So I had to put in a wine glass. So I'll bring it up to the camera. It's called the Brain on Fire shot. And I also took a picture that I'll post
it does look
on our socials.
Brainy.
It looks brainy and it looks scary. So wish me luck.
It's got texture.
It's got some chunks in it.
Oh, no, we talked about this. You said chunks are only for fruit.
I mean, it's not chunky because I know what's in it, but it looks chunky. So the Brain on Fire shot contains 1 ounce of peach schnapps, 0.5 ounces of Fireball, 0.5 ounces of Irish cream, and grenadine. So you first combine the Irish cream, Fireball, and apparently just 1 ice cube in a shaker, shake it up, mix it up real good. And then in a shot glass, you pour in the peach schnapps and then use the back of a spoon to layer the Fireball Irish cream combination on top, which does kind of layer there. It's only sinks slightly. And then you use a bottle cap to pour in just a couple of drops of grenadine, which gives it that bloody brain look. So shall I drink it?
Combination of flavors, peach and cinnamon and Irish cream.
Peach, I mean, Irish cream is basically like just cinnamon and not cardamom. It's basically just like a bunch of spices.
Okay. Let's
so
do
here
it.
I go.
All right, I have to narrate you. You narrated me the last time.
Okay.
All right. This is Nicole eating brains.
It's going to be really hard to do a shot in a wine glass, but they said it was sippable.
Okay. This is not The Walking Dead.
I'm going to do half of it. Okay, here we go. 1, 2, 3.
2, 3. Go, 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 go. Go, go. She did it.
I did the whole thing.
Oh, wow.
Honestly, it wasn't bad.
No?
No, it's not bad at all. It just looked bad and was a little chunky. Okay, so why did I torture myself? I tortured myself because the book and movie I'm going to talk about today is going to be, is called Brain on Fire, My Month of Madness by Susanna Cahalan. It was a book that she published in 2012. It is an autobiography. And then the movie came out in, where is my thing? In 2016 on Netflix, I believe. That's where I watched it, on Netflix. Released on Netflix in 2018. It was originally part of a film festival when it was first released. And then I guess Netflix bought the rights to it in 2018, and that's when it was released. So it is based on a true story. It is based on the life, or the early life, because she's still living and writing, an early life incident of Susanna Cahalan. She was a writer. I'm going to stop saying, that shot through me. Woo! It's just because it was like layered. It's like I feel like there's 2 layers sitting in my stomach. Maybe it wasn't that good after all. Sorry, guys. So she was a writer for the New York Post, and she'd been there. They didn't really say how long she'd been there, but she clearly was one of the younger writers, one of the new writers trying to really like get these good stories and be up and coming. And so she starts to begin to experience some odd symptoms. At first, she is having like flu-like symptoms where she has a cough and she's tired. And then she starts having these odd translate states, and she thinks she's hearing people talking about her. She's very, very sensitive to loud noises. And if you could just imagine living in New York City, there were loud noises everywhere. So she was really going through it in the beginning. And then over time, so at the time that this happened, she's 21 years old, so very young. Mm-hmm. So that's why I said like she was like a young writer, young cub reporter. And in the movie, she is played by Chloe Grace Moretz. In the movie is also Jenny Slade, Tyler Perry, Carrie-Anne Moss, and it was produced by Charlize Theron. I just throw those names out there because they're names a lot of people know. So it was, some pretty good people signed on to this film. So as Susanna continues to decline and get sicker and sicker, she's really struggling at work, but she's insistent that like, this is my dream job. I've worked my whole life. I'm going to keep doing this. And so her behavior starts to become very erratic. And there's this one part in the film. It wasn't really talked about too much in the book, so it probably was, dramatized for the film. But she's supposed to do this really big interview, and she's just freaking out. Like she's laughing at the guy, and then she's screaming, and then she's hiding under the table, and everyone's like, what the heck is going on? Jeez. Very, very bizarre behavior. And so as her behavior gets more and more erratic, she kind of withdraws. She's not really talking to family as much. She's not seeing her boyfriend as much. There's this one scene in the movie where she's at work, and you don't even know she's at work until like further on in the scene. It looks like she's in a dark room, and she's talking to her boyfriend on the cell phone, and basically telling him like, I don't feel well, like something's wrong, I don't know what to do. And then we realize she's hiding under her desk at work in the middle of the day.
Jeez.
Yeah. So she comes out, and she has light sensitivity. She's just not really doing well. And everybody at work thinks, oh, she must be high. She must be drunk. Like she's using drugs. Something has to be connected to this sudden change in behavior, because they do feel like this is not who she typically is, but something is wrong. And they're trying to find what the most reasonable explanation would be. And for a 21-year-old, partying too much, working too much, work too hard during the day, party too hard at night could lead to some of this erratic behavior. So everybody's kind of concerned, but nobody really says much about it until Susanna has her first seizure. And then her boyfriend witnesses this. And so he immediately takes her to the hospital. And even when they show the seizure in the movie, it's very unusual for people who know what seizures look like. It doesn't even present the same way. Basically, she's asleep in bed with her boyfriend, and she just jolts, sits up straight, and is like staring into space, almost like catatonic. And then he's like, what's going on? What's wrong? And then she kind of like lays back down a little bit and then goes into a classic clonic-tonic seizure. So that's not a typical seizure presentation. It can be, but definitely the way that they were dramatizing it didn't come across as a typical seizure. And I'm assuming that's because we do then learn it's not a seizure disorder or something like that. So after all of that, she goes to the hospital. They basically kind of blow her off, like, oh, follow up with neurology, like you're fine. And she's very insistent on that. She's just working too much. She needs to get more sleep. The doctor thinks she's partying too much. They do like a whole workup for alcoholism. And she's like, yeah, like I drink a couple of times. I'll smoke here and there, but like nothing excessive. And they really don't believe her. So after the seizure, because her boyfriend is so concerned, he contacts her family, and her parents are divorced. So there's some contention between the two of them, but they do come together, you know, for the best of their daughter. And they show earlier in the film that they seem to have a good co-parenting relationship, just despite not being together. So the boyfriend is concerned about Susanna staying in her apartment by herself, and he can't really be there for her the whole time. So she ends up moving in with her mother and has more odd emotional behaviors. At one point, she like grabs a knife from the kitchen and is like kind of walking around with it. And she's refusing to take medications that have been prescribed to her because she says they're going to make her crazy. And just very, very bizarre behavior and emotional outbursts. So her mother decides to take her into a clinic where she has an MRI, which before all of this, in the movie anyway, she had had an MRI when she was just not feeling well. She'd gone to her primary care, mentioned these symptoms, and the primary care alludes to thinking it might be like meningitis or something. So he sends her for an MRI. The MRI comes back clear. So he's like, oh, you're fine. Just get some rest. So after this outburst with her mother, they take her to the hospital. She has an MRI, and they're basically like, oh, well, this is like classic bipolar. Like she's at the right age, she's got a high stress job. Like this is what it looks like. So her mother's trying her best to take care of her, but she really can't handle it. And in the movie, there's this one really poignant scene where the mom is like, I don't even think she's left the house. She's just in another room. And then all of a sudden she gets like this bad feeling, like, where's Susanna? And she's calling out for her, and she's looking all over for her. And she finds her in the pool, like fully clothed, just floating there. And she's like, okay, come on, like get out of the pool. And she refuses to get out of the pool. And so she's like, okay, something's not right here. So then her father is like, you know what, I'll take her. Have her come live with me. We can handle it. And again, her behavior is very erratic, up and down. And so one night in the movie, one night during dinner, she just totally loses it. And she has this big outburst at her father's girlfriend, his fiance, and is basically like saying like, oh, you hate me. You're talking shit about me. I just heard you, when it's like total silence. Like she's hallucinating clearly. And the father's trying to help her, and she freaks out. She starts throwing glasses, and then she's in the corner screaming, and the dad tries to like console her, and she's like, don't touch me. Nobody can touch me. And she's really, really freaking out. So they bring her back to the hospital, and the hospital diagnoses her with schizophrenia. And that if her behavior doesn't improve with the medication regimen that they're going to have to transfer her to a psychiatric hospital for long-term care. And so, of course, her parents the whole time are like, this isn't adding up. Like, it doesn't feel right. There's no family history. Like, she's never had any mental health concerns at all before. Like, this is all very sudden, and it just doesn't add up. Like, it doesn't feel like her, which I think can be hard for a lot of parents and family members when someone has those prodromal symptoms of schizophrenia to come to terms with, my family member has a serious mental health concern. So I feel like their reaction was kind of normal. I think a lot of parents would feel that way. And unfortunately, it's having those conversations about like, this is the age that these symptoms can come up, and this is what it looks like. And, it is really hard. It can feel like a sudden change. But for some reason, her team of doctors also are not 1,000% convinced that it's schizophrenia.
Oh.
So they decide that they're going to monitor her for a week. And if there's no change in a week, then she's going to get transferred to a bed in a psychiatric hospital. I believe they talk about sending her to Bellevue, but it's in New York, and Bellevue's a big famous psych hospital. It's also a regular hospital for those who don't know. But I think maybe they just threw in Bellevue for, the dramatic effect of it. So while her team is trying to figure out what the heck is going on, she continues to decline, and she becomes catatonic. And so for folks who don't know what catatonia is, because I think there's a lot of misconceptions about it, catatonia is essentially when you're no longer verbally responsive, maybe not even visually responsive, but you're still awake, you still have a heartbeat, like all your vital signs are appropriate to a healthy human being, but you're just not there, you're not responding. And a lot of times when someone has schizophrenia, they can have what we call a waxy cataplexia. So that is when you can kind of move their arms and they just stay there. So like you can position people, or they position themselves and their arms just stay there. Like your arms could stay up in the air for hours if you have catatonia.
That's crazy to me.
It is crazy. It's very unsettling to see. I have never seen it in person, knock on wood. But I will say it can be very upsetting for family members to see stuff like that. There's one scene in the hospital where her arms are like straight up in the air and her mother's like, Susanna, put your arms down, put your arms down. And like they literally have to like push her arms down because her muscles are like rigid and staying up there. And so as they see this decline, they're like, this is schizophrenia. This is what it looks like. But what I think is really interesting in the newest iteration of the DSM 5-TR, they changed. So catatonia was never a disorder or a diagnosis of its own. It was always a specifier. It was always a symptom of something else.
Right.
And apparently it happens often enough that now it's a specifier. So a specifier, for those who don't know, when you're diagnosing, is something that you would tack on that can go with that disorder. So at this point, catatonia can be a specifier with depression, with schizophrenia, with severe anxiety, with things like that. So it's saying that this is an additional symptom that some people have, but not every person has. And that symptom itself, the catatonia, is not part of the disorder. It's just almost like a byproduct of the disorder, if that makes sense. So once she's starting to be catatonic, it's extremely hard for them to try to assess what's going on with her, especially if it's a mental health issue. Because if someone's not talking to you, they're not responding, they're kind of just sitting there staring for hours at a time, you can't assess someone. You can't determine, okay, are they psychotic? Do they have good reality testing? Are they able to communicate if they're in pain? You know, can they respond to directives? It's very, very difficult. So in the movie, this gets dragged out quite a bit. In the book, it goes more into the details of what the medical team is thinking. In the movie, they kind of just glaze over that, probably for dramatic effect. You know, you don't want the audience to know exactly what you're thinking every step of the way.
Right.
But at one point, they call in a consultant, Dr. Suhail Najjar, and he is I want to find his appropriate title. He's a Syrian-American neurologist, and at the time he's teaching, so he's no longer practicing. But one of the doctors on Susanna's team, he was a former teacher of hers, and so she goes to consult with him, and he's like, I don't do treatment anymore. Like, you guys will figure it out. You have an amazing team. And then she basically like tells him enough information that he gets intrigued, and he's like, okay, I'll visit her once, but like no promises. And so he goes and he sees her and he meets her family, and he's an amazing doctor in the movie anyway, which, you know, it's based on a true story, so I'm sure the real doctor was amazing. But he has a wonderful bedside manner, and like he sees her parents are just shaken by this, and he's like, we're going to find your daughter. She's in there somewhere. You just have to give me time. I need to figure it out. But, you know, she's in there. She's not lost forever. And so he begins to do a bunch of testing and brain scans, and they have cameras in her room to monitor her 24/7, and they do EEGs and EKGs and every testing you can think of they're doing to try to figure out what the hell is going wrong with her. And every test comes up normal. So they're like, okay, this has to be a mental health thing. Like, if all of this stuff that looks like it could be neurological is coming up normal, that's the only other decision. So now things at the hospital are getting really tense because, as I'm sure you know, in a lot of hospitals, there's a limited number of beds and there's a maximum number of patients. And so especially if someone's not responding to treatment, they're not going to keep them in a regular hospital bed. They're going to transfer them to a rehabilitation or a long-term care or something like that to free up that bed for someone else who they can help. And so they have this conversation with her parents, and they're like, look, we've only got like 3 days left until we have to transfer her. Like, we can't keep her here. Nothing that we're doing is helping. So we're not, taking care away from her. We're just transferring her care to another facility. And her parents are getting really hopeless. The boyfriend, super sweet. He's there like every day. And there's like this really cute thing where like at first, like the dad is like, oh, I don't like you. Like, you're with my girlfriend. And then like the dad comes one day to visit and like sees like the boyfriend like sitting on the floor in the hallway, like asleep. And he's like, come on, buddy, like, let's get you a coffee. Like, and then they have a little bonding moment. It's very cute. So at this point, and I don't know why they waited this long, because I don't know about you, but I've given this test before in an intake or, relatively early on with meeting someone, but he has her do a clock drawing. So do you know about clock drawings and why we do them?
I mean, I know in dementia patients we do it. It's one of the quick, very easy things that you can do with a dementia patient. That's really the only place that I would typically do it.
Yeah. So a clock drawing, basically when we ask someone to draw a clock, we'll ask them to draw a clock and then we'll tell them what time to put on the clock. And the point of that is looking at multiple things. We're looking at your motor ability. Do you still have fine motor functioning to be able to draw the circle, to be able to write the numbers? Do you have the perceptual ability to write the numbers correctly and write them within the circle instead of outside the circle? So it's looking at several different neuro things in like a very quick and easy thing, draw a clock. So the point when he asked her to draw the clock, she's catatonic. So I was like, this is going to be interesting. So they kind of take it slowly, where they put the paper in front of her and then they put a pencil in her hand and they help guide her hand to the paper. And every once in a while in this catatonic state, she's sort of communicating with blinks, like not really like blink once for yes, blink two for no, but like they can tell that like she's at least hearing because she's responding slightly. So he basically says to her, like, can you draw a clock for me? And then they don't show her drawing it. They actually don't even show this clock for like 25 minutes. And I'm like, what's the clock look like? Come on. And then he's like staring at it and he's looking through research studies and he's like, you could tell it's like 2 a.m. and he's drinking a fifth coffee and staring at this clock drawing. And then he gets up and pins it on a bulletin board and it's only half the clock. So everything is written on one side. So I'm not a neurologist. I'm not a neuropsychologist. But I know if there is a sided neglect, left-sided neglect, right-sided neglect, that can mean several different things, but usually it's about one part of the brain, one of the hemispheres of the brain, like we talked about last episode. Yes. There's a problem, usually some sort of inflammation, maybe seizure disorder, something like that. But something is happening on one side of the brain where the other side of the brain is still essentially intact. And so when you're drawing a picture, as we talked last week about the visual processing, you need both sides of your brain because it's contralateral. So if she's only drawing one side of the clock, that means one side of the brain is not working correctly.
It's not working. Yeah.
So they don't say exactly how he gets from A to B on this, but it is the correct diagnosis. So I'm not challenging him. But he basically comes to the conclusion that they need to do a brain biopsy because her brain is inflamed. And he's decided that based on her only drawing the right side of the clock face, the right hemisphere of her brain is swollen because it's contralateral. So if you draw the right side of the clock face, the left side is working, but the right side is not. Does that make sense?
Yes. Question, just all the tests they did, I assume they did a lumbar puncture somewhere before all this.
They did.
Okay.
They did.
Okay.
And that came up normal, which I start to question when we find out what the final diagnosis is, because I feel like it should have come up on that. But...
Unless maybe they didn't test for all the different markers. LP, there's different things you can
have to specify
check
what
off
you're
that
going to
right.
And they're not going to test for every possible thing because there's a bajillion possible things.
Right.
So that's probably more than likely what happened was they only tested for a certain profile of possible disorders. So they do this brain biopsy, which they make it, again, sound a lot worse than it is. Not that it's not bad, but they're not like breaking open your whole skull and scooping out pieces with like an ice cream scooper. Like they drill a very, very small hole, they take a very small sample, and they test it, and it comes back that she has, drum roll please, thank you, anti-NMDA receptor encephalitis.
Yes.
Have you heard of that?
I have. I know it's rare and it's that zebra.
It is. It's something that's, so the weird thing is that a lot of the sources say that it's rare. Then, for some reason, the NIH says it's a relatively common autoimmune encephalitis. So I'm like, is it relatively common in people who have encephalitis?
I think so. I think of the autoimmune encephalitis
it's the common one. Yeah,
I guess.
So for those of you who don't know, encephalitis is essentially swelling in your brain, or it can be like fluid on your brain. But it's basically something with the literal visual parts of your brain are swelling. They're not in the normal status. Right. And encephalitis, swelling in your brain, can cause disruption because, long story short, your skull doesn't get any bigger. So your brain is this size, your skull is slightly larger. If your brain swells and it starts to press against your skull, and that can cause lots of damage. Because what a lot of people don't know, and this is from my TBI background, the inside of your brain is all spiny. The inside of your skull is all spiny. So if you're pressing against that, you're puncturing little holes in the brain, causing other type of damage. So any sort of encephalitis, any sort of swelling in the brain, we want to reduce that as soon as possible. Same thing with any sort of brain injury. We want to prevent our squishy little jello brain from slapping against the bony skull as often as possible. Yeah. We don't want that to happen. So the anti-NMDA encephalitis means an autoimmune response. So essentially your body is attacking the brain. NMDA are receptors in the brain. And so the autoimmune response is attacking specifically those receptors in the brain and then causing the swelling in the brain. So common signs and symptoms of this, they vary in severity. A lot of people start with the less severe symptoms, and then over time they get worse unless it's treated or caught, which a lot of times, because for a very, very long time it was considered extremely rare, a lot of people weren't having it caught right away. And so they were having more severe symptoms. But the common symptoms are essentially what we're seeing in Susanna, a lot of erratic, psychotic-like behavior, paranoia, hallucinations, aggressions, delusions, difficulty with cognition, memory problems, speech problems, loss of consciousness, movement disorders. So that can be like rhythmic movement of the arms or legs, or just abnormal movements, especially in the face and the mouth, seizures, and then autonomic dysfunction. Do you want to describe what autonomic dysfunction is?
So autonomic dysfunction is essentially your brain should be telling your certain organs like your GI tract and your heart to do certain things, and dysfunction is sort of a disconnect there. So that happens sometimes after brain injury. We see it with other autoimmune disorders, but essentially somebody who changes position, their heart rate goes crazy, or their gut doesn't move appropriately, that would be, or somebody who sweats inappropriately, that would be autonomic dysfunction. It's out of proportion and it's not congruent with what it should be doing.
Yeah, and if it continues to happen, it can cause damage to other parts of your body. So it's important to, if you are having that autonomic dysfunction, to have it addressed as soon as possible so it doesn't cause other complications. So according to UPenn, diagnosis is made through cerebral spinal fluid, which would be a spinal tap, but that is not how they caught it in Susanna. Now, I will say, I'm skipping ahead, spoiler alert, when she is diagnosed, she is only the 217th person to ever be diagnosed with it.
Wow.
So that kind of tells you how rare it is, but two, also like how difficult it is for someone to get that diagnosis and then to do well after. So she was very lucky because she had this team that was on her side and was really, they were not convinced that it was a psychiatric illness. And so,
I mean, I could see so many times this being just brushed off. Okay, keep giving them meds. Okay, they didn't improve, send them to long term. I mean, this could get missed quite a bit.
Yeah. And the doctor that diagnosed her, Dr. Najjar, he had said that at the time that he was doing the diagnosis for Susanna, that approximately only 10% of people were properly diagnosed at that time. And so since then, there's been a lot better understanding. She did eventually go on to write this autobiography that I'm referencing, and then it became a movie. And they have tracked it and have said that since the movie and the book release, a lot more people are getting diagnosed appropriately since then. So it really has done a lot of positive. My problem with the book and the movie is that the book, it goes into detail about her recovery as well. But the movie is basically like, this is what it is. We can treat it. And then 6 months later, she's at home. And then a year later, she's back at work. And then it's like, wait, what? Where in real life, she had to relearn to walk. She had to start from like basics to get back to real life. So I don't know if she actually did return to work within a year. She did eventually return to work because she did work for the New York Times at some point. And as I said before, she is a best-selling author currently. But I don't know if they just, again, for dramatic effect and everything like that. But it seems like they really just rushed through her recovery once a diagnosis was made. But I guess maybe that's kind of the point of these kind of mystery illness shows is we just need to know what it is. And
this is like the epilogue, like, okay, here, happy ending.
And then so some of the treatments, which they do reference that she's had these treatments, are plasma exchange, steroids, IV immunoglobulin, and then there's some other medication treatments that you might have to use longer term. They said that the recovery, full recovery can happen usually about within 2 years with the appropriate treatment. However, in this article from UPenn, it says that sometimes someone may have a tumor associated with this. And so it really depends on the growth of the tumor, the ability to remove it, things like that. But if you're having the type that Susanna seemed to have, it looks like once they identify it and then are doing these type of treatments, the recovery, the prognosis is pretty good. There was a note in this that said the tumors are not always necessarily in the brain. So it said one of the most common tumors associated with it is an ovarian teratoma.
Oh.
So that's kind of interesting because we know autoimmune things can affect your whole body. So that makes sense. But it's kind of like, okay, you're coming in for these psychiatric symptoms, and then we've decided your brain is inflamed, but now we got to check your ovaries.
Yeah.
And so I can imagine that maybe not every doctor who's as well versed in this very relatively rare disorder is going to know all of those things that can be connected and to check on those things. And I mentioned that the ovarian teratoma is associated with it because it does seem to happen for some reason more commonly in women, but it can affect both men and women, and it primarily affects the young, including children and young adults. So this is something that if you do have it, you're probably going to see symptoms relatively young, like Susanna was. So there's a wonderful website, it's going to be linked in the show notes, called the Anti-NMDA Receptor Encephalitis Foundation, which has lots of information, wonderful patient stories. What I really like about their website is they have things in multiple languages. So all of their articles are in English, French, and Spanish and Italian. So I think that's really important, especially because, like I said, Susanna was only the 217th person in the world diagnosed with it. So I'm glad that they're spreading this information in other languages so it's available to as many people as possible. Chances of relapse. So that's something they don't talk about in the movie because at the end of the movie, she's all better. But relapses can occur in up to 25% of patients. Then there's no test to predict who's going to have a relapse or not. You kind of just have to monitor it. And immune suppressing medications typically need to be taken for a prolonged period, even after recovery, just to prevent relapse or further issues. It's not contagious. And as far as we know, it is not hereditary. So it's kind of just a funky thing that happens. Like, unfortunately,
I tell patients this sometimes, like strike of lightning. I'm sorry, it's bad luck. Like there's literally nothing you could do to cause or prevent.
Yeah. So that's my story, and I'm sticking to it.
Yeah, I remember, the movie being out, and it was just one of those things like, I'll get to it. And I knew peripherally about the disorder. And I think after that, I did see more things on it, and I knew about it. And I always like to look for zebras. So, it'd be somewhere in my differential, but with someone with such acute symptoms, it's unlikely I'm going to see them.
Well, and it's funny you say that because I just found the list of possible differentials. So other autoimmune encephalitis, psychiatric disorder like we talked about, viral encephalitis, neuroleptic malignant syndrome, which I could do a whole episode on that because I feel like a lot of people don't know about that. Catatonia, which this site needs to be updated because catatonia is not a disorder in and of itself. Acute disseminated encephalomyelitis.
Oh, myelitis.
Myelitis. Okay. Mitochondrial encephalitis, which I actually just watched a different movie about someone possibly having that and then not having it. Cerebral space occupying lesions.
Well, that's a mass of any kind.
Yeah, no, but I just like the way that it's phrased. I was like, ooh, that sounds fancy. Space occupying. And then exposure to drugs, toxins, or withdrawal. So those are the typical things that if someone's presenting with some of these symptoms, they're going to rule those things out. Probably rule those ones out first because I think a lot of those are easier to diagnose versus the anti-NMDA receptor encephalitis.
I also think because she had like a support system and a family and all of that, it probably helped. I think some of these patients who may show up with really nobody to give you any of the history on them or any details or get brushed off and missed.
Absolutely. And I think that's so true in anyone who's presenting with any sort of psychiatric symptoms, because unfortunately, despite how far we've come in the US, there is still a lot of stigma about people with mental illness, especially people who are unhoused and mentally ill or veterans who are mentally ill. And so I think the more of a support system you have, people to advocate for you, the better your treatment outcomes are going to be for anything, but especially in the mental health world. And then we found out that, in general recovery, the more of a support system you have, the better your outcome is going to be. So it's helping both to advocate for treatment and then ultimately for recovery.
Yeah.
Welcome to my TED Talk. Thank you.
Just like turn these all into TED Talks. We're good.
I would love that. I don't think I say too many ums for TED. They wouldn't like me.
Is TED a person? Like, is there a real TED?
No, it stands for something I can't remember off the top of my head.
Oh, yeah, it's all caps, TED.
Yeah.
Man, we're smart. We're not that smart. We don't know what TED stands for.
Let's not underestimate ourselves. We just don't know what it means now. We can find out. If you guys are interested in Susanna Cahalan, she just released a more recent book. I just had it that has been pretty popular. I want to get the title right. The Great Pretender, the Undercover Mission That Changed Our Understanding of Madness. And so for those of you who love psych and took Psych 101, you've probably heard about this, but she's basically going in depth into a research study that occurred back in the day where psychology students admitted themselves into psychiatric hospitals, pretending to be psychotic and wanted to see how long they'd be stuck there. And so I'm not going to give you any more information, but her book is basically talking more about that process and what it means about mental health and mental health treatment.
Interesting.
Yeah. I might have to read that book and then cover it on another episode, but I know the whole background story. We learned about it.
Cool. I like that one. All right. We ready for my turn?
I'm ready.
All right. So my cocktail is the MMR, the Mango Mojito Refresher.
Not the measles, mumps, rubella?
Maybe.
That's what it stands for, right? Did I get it right?
Yes. So the recipe calls for making your own mint simple syrup. It's actually easier than cooking it on the stove. Is to literally pour all those things in a little ramekin and put it in the microwave. So I did. It's 50. So simple syrup is always 50% sugar, 50% water, and then throw a few mint sprigs in there and microwave it for a couple of minutes until it blends. And there you go. You don't have to do it on the stove.
Nice.
So that's what I did. And then basically you take a fresh lime cut into small circles, 4 to 8 mint leaves. I say heavier on the mint, the better. 3 ounces of mango nectar or juice. I did find nectar, which I think it makes it a little bit better. It's a little more to it. And then 1.5 ounces of the simple syrup that you had made, 2 ounces of white or light rum. You could always leave that out. Crushed ice and club soda. So you start in the bottom with the limes and the simple syrup, muddle that a little, throw your mint leaves in, muddle that a little bit, and then you layer on the rum, the nectar, and then pour the ice. I'm sorry, first ice, then rum, nectar, and then pour your little soda over the top. I did have to mix mine because the mango kind of fell because it was heavivier.
Yeah, the nectar is very heavy.
And it was all just rum at the top. So I did have to take a straw and mix it before because when I was drinking it, I was like, woof, that's a little too much.
Mix it. Last.
But it was pretty. So I'll have to send you the picture. We can put that up with the recipes.
It sounded good when I was typing up the recipe for our socials. I was like, I need to try this.
Yeah, I mean, mango mojitos. I mean, you can't go wrong. Mojitos are nice. I do like. So I am covering the TV show Outlander.
Well,
have you watched it?
Not all of it. I think I stopped at whatever season when the daughter's like, I'm going to go back.
Okay.
I don't want to give too many spoilers, but whatever season that was the last season I saw.
Okay. So what we'll tell you a little, everyone, the listeners, a little bit about the show. But what I'm covering is episodes 405 and 406, which are in the 4th season. And
all they need to know about the show is Irish kilts and shirtless hot men. That's all they need to know.
Not Irish, Scottish.
Sorry.
Get it right.
Scottish kilts and shirtless hot men.
Seriously, I didn't.
There's also time travel, but like, does it matter what time we're in?
Jamie Fraser. That's all I have to say.
I'm so sad. We almost got to meet the Outlander cast, but we had tickets for the wrong day of Comic-Con because they don't announce who's going until after you buy the tickets. So we didn't know, but.
Oh, no. Seriously. I didn't know I had a thing for Scots until I met him.
You met him?
No, until I met him on screen. So for those who don't know, Outlander is a historical drama TV series, but it's actually based on a book series by Diana Gabaldon. And I actually read the first 2-ish books, and then I started watching the series. And honestly, the series is so good that I feel like I didn't even need to read the books because the series
books as spicy as a series.
Yes. And it is fun. And maybe I'll go back. I think there might be like 10 of them now.
Yeah, there's a lot of them.
Yeah. So, but it's just really well done. The series is really well done. So it premiered on Starz in 2014. And the main characters is the first is Claire, who's well,
for those of you who don't have Starz, I believe 4 seasons are on Netflix. Not all of them.
5 are on
Netflix.
Maybe even 6. No, I think 6. Because 7 is the last one and that one's not there, but everything else. Because I went back and I was like, oh, I didn't watch this last season. So I started watching it after I was inspired for the podcast to go back to it. Yeah. So Claire Randall, who is one of the main characters, played by Catriona Balfe. She's a World War II military nurse who's in Scotland in 1945. Actually, I believe she is on her honeymoon or a trip with her husband. I think just a trip with her husband. Mm-hmm. And she goes up to this area that's sort of Stonehenge-y looking. And somehow she is magically transported back to the year 1743.
It's not magic, it's fate.
It is. It is.
He learned nothing.
I mean, it is for sure fate. The two of them, they were fated.
And her husband, he's part of it too. They're all connected. Yeah.
So she ends up meeting Jamie Fraser, who's played by Sam Hogan. I don't know how Heughan. I don't know. I don't want to mispronounce it.
Just Sam.
But he is a very handsome Scotsman, and he's from the Clan Fraser. And, basically, historically, this sort of follows real history. So it's pretty interesting because I didn't know too much about Scottish history and the Jacobite Rising. So, like I said, it's pretty interesting. So where we find ourselves, where I'm looking, is just after the Battle of Culloden, which is a big battle that happens in Scotland. And right after that, Claire actually returns to her own time because she knows the Battle of Culloden takes out many Scots, and she figures Jamie's going to end up dying, and, let me go back. And she happens to be pregnant. So she goes back to her own time. 20 years later, and I'm not giving crazy spoilers because it's a great show. Watch it. 20 years later, when the daughter that she was pregnant with is Brianna, who's now, I guess, 20 years old, she decides, well, she's grown. She went back to her husband in real time, and he ends up dying in a car accident. And in the interim, she actually became a physician. So she was a nurse before she went. She becomes a physician and actually a surgeon. And so she decides, I'm going back. She found in a book that Jamie's still alive, and she's like, I need to go back. So she ends up going back. And so she returns somewhere in the 1760s and meets back up with Jamie, and things happen. So I'm going to give you every little detail, but essentially where we are is now they've gone from Scotland, and now they're in the Americas. And so this is pre-Revolutionary War, right around that time. The Brits are still heavily involved. And Jamie had been working himself through the politics of Europe over the past however many years, and he ends up being given 10,000 acres of land to develop, and he calls it Fraser's Ridge. So they're building a home. This is located in North Carolina. They seem to be very friendly with the Native Americans, him and Claire. And in the beginning of this episode, 405 and 406, I'm looking at the beginning of episode 405, you see Claire learning from one of the Native American healers. And then you see her helping a German family with their daughter who just had a baby. You see the father, the German father, come back, and he gives this doll, he picked up on the road, wherever, from a vendor for the baby. And they named the baby Clara after Claire because she helped deliver the baby when they were in need. While she's at the house helping this family, tensions raise when some Native Americans come and drink from the creek right outside their home. And basically it ends up with sort of a standoff of the German father coming out with his gun and threatening them, and the Native Americans raising their guns and threatening, and Claire standing in the middle because she's friends with everybody and just understands that they're just people. But at that time, they thought Native Americans were savages, right? That's what they called them. And so she kind of diffuses the situation, and she goes back to her cabin. Her work is done with helping the baby, and she's alone for a few nights because Jamie had to go into town to do a couple of things. Then one day, the pastor of this area comes to warn her that the German girl and the baby died of measles. Mm. And that the father blames her. And he thinks it's because she let the, quote, Indians, Native Americans, curse their water. So, of course, Claire is worried that this German guy is going to come after her. She's alone in this cabin in the middle of the woods in North Carolina. So you see her like sleeping in her rocking chair with a gun, all of these things. Eventually he does come. And he says, I came to see if you're okay, if you caught the measles, and they died. And he said they died so quick. He said the curse was strong. And he said, my wife and I didn't get it because we had measles back in Germany and we were only sick for a week, though. We didn't die. And you see him pull out this something wrapped in a towel. It's the same towel that he brought the baby's doll wrapped in. So Claire thinks, oh, he's going to give me the doll, from the baby that was named after me. And when she opens it up, it's the scalp of the healer woman who she was working with in the first episode, the Native American healer.
I mean, I know it was like a thing that happened, but doesn't it feel like a little racist that the Indian guy scalped somebody?
Well, no, the German guy scalped the Indian.
Oh, I thought you were saying the other way around. Okay.
No, so he killed the healer, the Native American healer, in retaliation, essentially.
Oh, for
because they cursed the water and killed,
the hymns confused.
Yes, German man. So he leaves, Claire's shocked. He leaves to go home. And
what did she do with the scalp?
She actually did like this little ceremony and put it in the fire to burn it because that was her friend and like sent her spirit off. So we see German guy go back to his house and we see the Native Americans then setting his house on fire with flaming arrows and his wife coming out of the house with an flaming arrow through her and dying.
I'm sorry, I have this weird face for if this ever becomes a clip because I'm trying to track in my head if measles can be passed on through the cloth that it was wrapped in. But then I'm like, no, that's smallpox. But like, I don't know if they're similar.
Yeah, this has nothing to do with that. So, yeah. So basically the German guy comes home to see his wife dying, all the retaliation, all the tension between the Native Americans and the others. And so it's just kind of sad because it shows that Claire, remember, she came from our time. She understands germ theory. She understands what this is. And she's trying to explain it. And she's desperate to keep like everything calm between these people. And it's pretty sad, So basically at the end of that episode, Jamie comes home and she kind of falls into his arms. But essentially in town, there's been a measles outbreak. That's where this came from. This came from people. It always comes from people. So we never, during that episode, got to see the daughter, Petronella, and her baby with the measles. We didn't get to see what that looked like, what the disease looked like. But in the next episode, some more things happen, so we're able to see a little bit more of what it looks like. So Lord John Grey, who's someone Jamie knows from his past, very complicated, not going to go into that. Very, very complicated.
It gets very messy with him.
He is in and out of Jamie's life. Well, we're just going to say for a long time. He comes
not always in a good way. Spoiler alert.
And he comes up to their cabin and great to see you and whatever, to see Jamie and Claire and Murtaugh, who I didn't tell you about, but they're out in the woods and they happen to see a boy sitting on a rock and yelling, "Help, help, help." And the boy has leeches on him. "I want my father." And, Claire's like, the leeches will fall off. You'll be fine. But the boy's like very uppity, dressed in
wine, and they're just leeches.
Right. He's dressed to the nines. He looked like he's never been, out in the woods and whatever. So essentially this is Lord John Grey's son, who we know other things about, but I'm not going to tell you anything else about that because it's a big spoiler. But anyway.
I definitely remember that part of it.
Yes. So Jamie invites them, stay with us, and we'll catch up on everything. And Lord John mentions that his wife, his son's mother, passed away and that he and his son are here in the Americas now. So they again speak about how there is a measles outbreak in the town. And right before the end of Lord Grey's stay, the day he's about to leave, he starts to have a fever. So the first thing Claire does is she checks his mouth, which I'm going to, tell you now, and I'll tell you later during the medical part, but there's a very specific thing to see in the mouth with measles. It's called Koplik spots. And those are essentially, we say, pathognomonic for measles. There's nothing else that looks like that. So she's like, well, he's got measles. So he starts coughing. He has a headache. So they make, the decision to have Jamie take the son, Willie, the son, out in the woods for a few days, go camping, go hunting, go fishing, toughen the boy up a little bit so he doesn't catch the measles. We know that Claire had the vaccine because she came from the 70s back, so she had the vaccine. And Jamie had measles as a child, so neither of them are concerned about getting it. So Claire stays with Lord John to help take care of him. And you see him go through all the stages of the illness. So it's actually a very good depiction of it. It shows him burning up. She's giving him willow bark tea for the fever, severe headache, the rash. You just kind of see this sort of montage of him going through all the stages. And then eventually see him recover and Willie and Jamie return. And then they end up, leaving and going on their way. But it was interesting, it was nice to see of the time, that we were able to understand the political climate, right? And the understanding between the Native Americans and those little tensions there. And then also to see a really great depiction of actually what measles looks like. So they did a good job with that. And it's that interesting perspective of Claire coming from a time where she knows everything about this. She's a physician coming back to a time where people knew very little about it, and her trying to help people with the knowledge that she has.
Well, and that comes up a lot of times throughout the show as she's always trying to prevent catastrophes with this future knowledge. And most of the time people ignore her or briefly she's called a witch. That's one of my favorite episodes.
Yes.
I love Gillis. But
Yes. So measles is very topical at the time. What's interesting is I had this on my list literally for the show months and months ago. Mm-hmm. We are today, February 27th is today. Yes. And there's been a lot of talk about measles because there's currently a decent sized outbreak in Texas, West Texas right now. And, I'll go through statistics at one point, but the biggest thing that we found out yesterday, this was the first death from this outbreak of a child from measles, and it is the first measles death in 10 years in the United States. So, that's pretty profound. Yes, we may have upcroppings of infection because this one has gotten so large so quickly. We've already had one death. Okay, so measles is very highly contagious. We did talk about this a little bit in episode 1. Remember when we talked about flu, we said the R naught of, say, flu is, I don't remember what it was, but it was like 1 to 2. Yeah. So one person infects 1 to 2 other people. Measles infects somewhere around 18 other people per one. That's 18 susceptible people, so they can be unvaccinated, too young to be vaccinated, or their vaccine immunity wore off. But it's a lot. One person can infect 18 people. It is, I believe it is the most infectious disease we have. And it is really transmitted the typical ways: infectious droplets, airborne spread with coughing and sneezing, and it can remain in the air for up to 2 hours after the person leaves the area. So it's just hanging there in the air waiting to get you. The onset usually is fairly delayed as well. So that's what's even more tricky with then tracking it, because you typically are exposed and then it's 7 to 14 days before you start with symptoms after exposure. So tracking back and contact tracing what somebody did 2 weeks ago and then who was contagious when is very tricky. And that's how this spreads like wildfire, because you're just living your life for the 2 weeks until you have symptoms, and you become contagious before you even have symptoms. Right. So typically, like flu-like things, you do often present with a high fever, and it actually can be above 104. So that's significant. Yeah. And the fever lasts 4 to 7 days. The prodromal phase is usually malaise, so fatigue, anorexia, so lack of appetite. And the thing that we learn in school, because we have, for your boards, there's the 3 C's. So conjunctivitis, cough, and coryza.
I only know what 2 of those are.
Yeah, so we know what conjunctivitis is. Cough, we know what that is. Coryza is just like a runny nose. I don't know why you don't use the word coryza in anything except for measles. I'm not sure. They just made it up to make a C. I'm not really sure. I've literally never used that except for a test question for measles.
Good to know. Now I can pass that question.
Other things you may have, so photophobia, lights bother you, swelling around your eyes, muscle aches. And then we talked about those Koplik spots. So they're bluish gray specks. They look like grains of sand on a red base on we call your buccal mucosa, opposite of your second molar. So that's if I took my mouth and I pulled it open and I looked on that sort of skin touching up to my molars, you're going to have these grayish specks there. It's very specific. Yeah. And you don't see it with anything else. It's not in your throat. It's not in your tongue. It's very specific. And that starts about 1 to 2 days before the rash, and they stay for about 3 to 5 days. You throwing things over there? What are you doing?
I moved my foot and I knocked over my shredder. Sorry.
It's okay. So the rash usually develops 14 days after exposure, so fairly early on in the disease. You can have mild itching, but it's not like chickenpox where you remember us all scratching like crazy. And you describe the rash as blanching. So when you're describing a rash, there's a lot of words.
I thought you said you described the ranch. And I was like, ranch dressing? What? I'm confused.
Sorry. Sometimes I realize that I do stumble over my words, and I apologize to everybody. My brain is ahead of my mouth.
I apologize for pointing it out. It just distracted me. I was like, huh?
So when we describe any kind of a rash, you have to use very specific terms. Nowadays, we can take a digital picture, I guess, and put it in the chart. But for all of millennia, you had to write these things on paper and hope the next person could read it and understand what you were speaking about. So when you're describing a rash, it's blanching this rash, which means the red, if you push on it with your finger, turns white and then turns back to pink. Erythematous, which is a fancy word for red. Macules, which are usually flat lesions. And papules, so if you think palpate, I can touch them. Papules, which are raised. They start on the face and they basically work their way down. And within 48 hours, they sort of what we call coalesce. So it's not like you're seeing discrete spots in that. It's just sort of everywhere, all over, touching each other, these patches that sort of are all connected. And it even includes your palms and soles. And when it does resolve, it also resolves the same way it came on, from the head down. And the most lesions you're going to see is usually above the shoulder. So chest, shoulders, like head is where everything's sort of just red. Sometimes you'll get bruising, or we call petechiae, which are little tiny blood blisters, if you want to think about it that way. And again, like we said, it lasts for 5-7 days, and then it sort of starts to resolve. And it can leave like these coppery brown, we call hyperpigmented, so more pigment patches, which then we call desquamate, which means skin peels. Uncomplicated measles, total can be about 10 days, and then the cough can linger a little bit. There are other things called modified measles and atypical measles, which are slightly different. Atypical is specifically people who were vaccinated with the original killed virus. So we'll go into the vaccines, but there was a period from 1963 to 1967 where the first vaccine they developed was a killed virus. It's a little bit less ineffective. So these people can get sort of a milder form of it, but they're not completely protected. Diagnosis nowadays, I mean, yes, clinical, but I would, of course, want to confirm that. So you can do blood work, and you may hear this in future things. When we check in blood work for immunity to certain things, we check things called IgM and IgG. So IgG is immunoglobulin. IgM is a different kind of immunoglobulin. So IgM is acute infection. IgG is resolved infection that you're now immune to, or you had a vaccine and you're immune to it. You can also do a swab for PCR, which I assume some lab somewhere can test that. I haven't looked up in like LabCorp and Quest in the major labs, but I assume somewhere in their book it says you can send a PCR for measles. So globally, measles is still a leading cause of death in young children. But of course, in this country, we've done pretty well with it, and it was for a moment eradicated in the year 2000. That was fairly short lasting, but it was eradicated. In the US, we do have outbreaks, but this Texas one is definitely bigger than ones we've had in the past. So as far as complications, this is where it gets a little tricky. So you can have that, we all had chickenpox and, everyone survived, but not everyone does with these, and we forget that. Yeah. So there are some major complications that can happen. And, the sort of biggest one, which is very interesting, is that we can develop sort of an immune amnesia. So
I'm listening. Go on.
Yeah. So measles can actually wipe out your immunity to other common things that you've developed immunity to. So other viruses you've had, other vaccines you've had, you've literally end up at the other end of it like a newborn baby with no immunity to any of this.
Wow.
And it can take 2 to 3 years to build that back up. So
would that ever be a good thing? Like, is there any way we could harness that ability to, like, somehow in science make that help in other ways, like learn to be immune to cancer or something? I don't know.
Yeah, I don't. Because of the type of immune cells that it goes after. It's these memory. Let me get to where that is. Specific type. I think it's memory B cells, but let me see. Measles, immune suppression, immune amnesia. Yeah, old memory cells if it's host with new MV specific lymphocytes. So it targets a very specific type of immune memory cell. So I don't think that's going to go for other things. Mm-hmm. It's more like infectious things. And then, other big complications, actually encephalitis, which is one of the things that you obviously spoke about. This would be a viral encephalitis, different kinds of pneumonia, because now your immune system's wiped out. So now you're susceptible to a bacterial pneumonia. You can have, if you carried latent tuberculosis, so you were exposed but didn't have it, it could become activated. So it's kind of scary in that end of things. There are the multitude of complication list is huge. I'm not going to read through all these crazy things that can happen, but it's not just a very simple illness. And 1 out of every 1,000 develops acute encephalitis, and it can be fatal in about 10% of them, and it can cause permanent brain damage. Wow. So, it's fairly scary. There are other things, a degenerative disease of the central nervous system called SSPE, and that is behavioral and intellectual deterioration and seizure. And that can not show up for like 10 years after you had it.
Wow.
Yeah. Treatment wise, like most viruses, it is mostly supportive treatment. So making sure you're hydrated, make sure you're breathing okay. They did discover that there are very specific doses of vitamin A that can be used once you have it to help reduce the risk. And if you are exposed to measles, there are post-exposure prophylaxis, kind of like we talked about with rabies. So there are things you can do. So you were contacted that you were in contact with somebody a few days ago. I believe it's within 3 days. Yeah, within 3 days of exposure. If you aren't sure your vaccine status or you aren't sure if you're fully immune, you can get a measles, mumps, rubella vaccine. And it's not going to hurt you to get an extra vaccine, even if you've already had it. Mm-hmm. So typically you err on that side of caution and you give it. The thing about the MMR vaccine is it is a live vaccine. So it has live virus in there. So there are a percentage of people who cannot have a live vaccine. So if they have undergoing chemotherapy, if they have certain cancers that affect the bone marrow, like leukemia and lymphoma, if they are on medications that are immunosuppressants. Now, we don't realize how actually pervasive not how pervasive, but how much we use immunosuppressants now. Mm-hmm. You see all those commercials every time you watch TV for psoriatic arthritis, rheumatoid arthritis, Crohn's disease.
That's
all
one
of
the
these
things they say at the end. Do not take if.
Right. So those are immunosuppressants because they're trying to treat the autoimmune disease. Those people cannot have live vaccines because they are at risk of then getting the infection, not being protected by it. So this isn't just, those few people who can't have it, right? There's a lot of people who can't have it. So in patients who cannot get a vaccine, pregnant women, children under 6 months, and those immunocompromised people, you can give a measles human IgG or immunoglobulin. So that can be given. Again, I'm not sure how you'd access it. Hopefully your state has a stockpile somewhere. I don't think they keep that in the hospitals regularly. but that's something that could be given. So, I mean, there are things we can do, but it's still pretty scary. And, we look back about this vaccine and how we created it, when it came about. It's fairly interesting. So they used this same strain of measles that they collected back in 1954 from a boarding school outside of Boston who had an outbreak, and they used that to collect specimens.
Did they get permission? Because we know what happened with Henrietta Lacks.
Yeah, it's true. I do not know. But they collected it from this boarding school. Oh, actually, they have a name, so I don't know. It's an 11-year-old schoolboy, David Edmonston. So whoever he is.
Did he survive?
They don't tell me. I assume he did okay. I don't know.
I assume he did okay. I assume that for everyone. I assume everyone's doing okay.
Yeah, but this Thomas Peebles, the doctor, obtained the virus culture, and then working with his boss, John Franklin Enders, who's the father of modern vaccines, they developed the measles from the Edmonston, after the kid, Edmondson B strain. And so they tested this measles vaccine on some groups of children in New York and in Nigeria. I'm not sure why they had to go to Nigeria to test it, but
two very different
there's
places. Probably
some...
Maybe they're both have high populations.
Yeah, I don't know. But in 1961, it was hailed as effective, and they put it out for public use in 1963. And, the World Health Organization, of course, started to push for that, getting it out worldwide. And then they created the improved version in 1968, where they actually were able to do a live vaccine, but put it through a chick embryo 40 times and cause it to be less side effects.
So many questions about that. So many questions.
Chick embryos, yeah. So this is called
40 times. Why not 32?
Well, that's called science and experimentation. So I bet they tried it one time.
Thank you
and
for
I bet they tried it 100 times, and all of the times in between.
It's called
and
science.
This one was not too small and not too much. It's like Goldilocks, right?
The Goldilocks effect. Thank you. I'm going to use that from now on when someone asks me why something. It's science.
So, they ran all the experiments. So that's called the Edmondson Ender strain, and basically is still used today. And then in 1971, they combined it with mumps and rubella. And then in 2005, they actually added chickenpox, varicella onto it. So, there's kind of, if you go between the world and the U.S., the timelines are slightly different. So I'll stick to the U.S. timeline because it's a little more streamlined. In 1978, the CDC set a goal to eliminate measles by 1982. The goal was not met, but it did drastically reduce the disease rate. So by 1981, the number of reported measles cases was 80% less than the previous year. It did have a bit of an increase again in 1989. And at that time, they decided to add a second dose of the MMR to the vaccine schedule. So, fun fact, we probably only got one shot because we were like 10 years old. Yep. 10 years old then. I don't know. I'd have to find some records. I've had titers because school, you have to.
Yeah, I've had them too.
And I've had extra vaccines because I wasn't immune to rubella. So I've had that again. So I've gotten the MMR now an extra 2 times. So and I've had titers, so I should be good. But yeah, so I was actually just doing somebody's paperwork the other day for admission to medical school, but they were our age, going like a little younger than us, but going back, and they only had one. I'm like, oh yeah, I just read about that, how there's only one vaccine back then. So now they give 2. And so in 2000, the U.S. declared that measles was eliminated. And that was defined by the absence of continuous spread for 12 months. There was, of course, a minor setback shortly after that due to, I'm not even going to say his name, but a gentleman who's not a gentleman who wrote falsely a paper, and he published it in The Lancet asserting that the MMR vaccine caused autism. And unfortunately, that became pervasive throughout culture.
A full episode on all of that.
became pervasive and scared a lot of people. And I understand people being scared because they just read that this doctor, the scientific paper that was published, said it.
Well, the crazy thing to me is that doctor was then forced eventually to write a retraction and say that he lied, and people still believe it's true. That drives me insane.
That's the tough part. That's the really tricky part. So that did reduce vaccination rates. Things went back up. And eventually he was not till 2010 though, he was, charged with misconduct and formally retracted and all of that. The thing about measles is because it's so highly infectious, we really need at least 95% vaccination or immunity among the population to prevent epidemics. Mm-hmm. So that's a really high number to achieve. And so that's why we see in pockets where that vaccination rate is lower and this can kind of sneak around and start spreading. And that's where we talk about herd immunity, right? So we need the herd to be protected, to have a high vaccination rate to protect those vulnerable people who cannot be vaccinated or are too young to be vaccinated. So, we're kind of sort of, like I said, going backwards. Hopefully this Texas one wakes everyone up and gets scared and everyone who's not vaccinated. I hope you get it. I understand there's a lot of information out there. Trust your medical providers. Talk to them. Trust the World Health Organization and the CDC. No one's out here trying to hurt anyone. We just want a healthy population. We don't want people dying. We don't want kids dying. Right now, 2 doses of the measles vaccine is 97% effective at preventing measles. 1 dose is 93% effective. So even 1 is better than nothing. So again, it's just about let's do our best to help prevent this. I'm going to give you some quick stats that are updated as of yesterday on this current Texas outbreak, which will be a month old by the time this airs.
You're putting me to shame with these stats from last week or from today.
Well, no, I'm going to shout out to one of my really great resources is your local epidemiologist. She came out during, her name is Caitlin Jetlina, and she is an epidemiologist, and she became very big during COVID and providing a lot of really great information. I subscribed to her emails.
Yeah, I remember you used to share her stuff a lot during COVID.
Yeah. So now I primarily follow her emails. So she put out some really good information yesterday. So, things we already talked about, this outbreak was kind of expected because we know that area does have low vaccination and we know how infectious measles is. We talked a little bit about how measles is not just a rash. Pneumonia is often a cause of death. And like we talked about, that immune amnesia. And it is unusual. There were comments recently by our health secretary who said this is no big deal. It is unusual because there's not been a death in the past 10 years. And we are only a few months, less than 2 months into the new year. And we're already hitting the amount of more cases than we've had in the past 10 years. So we have to look at it that way. So, we've had 4 outbreaks with more than 100 cases in the past 10 years. We are already up to, I think, 122, I believe, on this outbreak. There are patients hospitalized in this outbreak. Again, there was a false statement saying that they're being hospitalized for quarantine. That is not true. They're being hospitalized for medical issues related to it, whether it be encephalitis, trouble breathing. We said the 1 death, and it's not too late. If you live in this area, please get vaccinated. It's very tough because it comes like a big wave, like a big tidal wave, and we just don't know how far it's going to go. I guess hopefully it stops when it reaches more geographically, at least reaches more highly vaccinated areas. But we live as we learned from COVID, we live in a world where you can get on a plane and travel anywhere, right? So anything can spread very, very quickly. Just a couple things that she clarified also in her emails. The epidemiologist, this is not a vaccine-derived strain. They've proven that because it is a D8 genotype, so it is not. And she said you can check your township's vaccination rates in schools if you have concerns. So that information is out there. And they're talking about, like we talked about briefly, if you're born before 1957, you're assumed to have had the virus. If you're born between 1957 and 1968, you may have had that lesser vaccine that was the killed vaccine. So they are saying you can go get another dose. You don't need to wait to check titers for that. And again, like it's not too late. Follow good sources. So your local epidemiologist is a great one. I would also say Unbiased Science, which they're a podcast, but they also have emails as well and social media posts. And Dr. Andrea Love, who also, she does a website called Immunologic, and she also does emails that are updated. So these are all scientists whose job it is to help inform us. They aren't medical physicians. They are statistics and lab driven and people who actually know how experiments are run. So they really can break down that information from papers really well. So I use them as a great resource for myself.
Nice.
That was a lot of talking.
It was a lot of talking. It was a lot.
So, it's interesting that we're still dealing with diseases that we had back in 1760s. So,
and I mean, I'm going to be 100% honest. For about 20 minutes, I was just staring at a picture of Sam Hugan. And I was like, oh, so
seriously.
I'll have to go back and re-listen for the parts I missed. Sorry. I got a little distracted by a pretty man.
All right. So another episode down.
Yes.
And I think we have a lot planned.
We do. We have a lot of exciting things planned, some fun stuff. There's a couple things I've been thinking about that I feel like might be more than one episode for just on my end. So yeah, we've got some fun stuff ahead for you guys, and we would love to hear your feedback. So you can always shoot us an email at medicalmediamixer@gmail.com, where you can follow us on our socials. We're on TikTok, Facebook, Pinterest, which I still don't understand why I made it, but I did. Instagram and YouTube. Did I get them all?
And Facebook.
I did say Facebook.
Oh, you did. Sorry.
I got them all. Yay.
Yeah, so we're there. We post little video clips if you want to see what we look like and are some of our silly antics that don't maybe translate on audio or better on video, brain not working. But yeah, some of the silly stuff that you hear is cracking up. You don't know what's going on. We post some of those. So definitely look for us. All right. So thank you for listening to Medical Media Mixer.
The perfect cocktail. Cheers.
Cheers.